Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started. Hey everyone, welcome back to the DNS Podcast. Today we're excited to talk about a key but often underutilized member of the nutrition care team, the Nutrition and Dietetics Technician Registered, also known as the NDTR. We'll explore how NDTRs working under the Academy of Nutrition and Dietetics scope of practice can help improve dietitian productivity, elevate clinical care, and optimize patient health outcomes. Joining us today is Sami Hupp, an NDTR with expertise in the integration of dietitian technicians working in clinical practice. She also has experience not just in clinical nutrition, but also food service management, and in general as a healthcare professional. She has a background in corrections, private practice, and nutrition advocacy. And of course, she's skilled in education, customer service, retail, and has a strong focus on improving patient care and promoting public health in the healthcare setting. Sami, thank you so much for joining us today on the DNS Podcast.
Yeah, thank you for having me. I'm so excited to be here.
So you are the very first NDTR that we've had on the show. So I think we should start with the basics. Can you explain the official scope of practice for NDTRs according to the Academy of Nutrition and Dietetics?
This is one of my favorite topics to speak on and educate others about. So I'm excited about this first question. The official scope of practice for NDTRs is established by the Academy of Nutrition and Dietetics and is served as the framework that outlines what NDTRs are educated and authorized to do. According to the Academy, NDTRs work under the supervision of RDNs, but we have our own unique scope of practice. NDTRs can perform nutrition screenings. We develop and implement nutrition care plans, monitor patient progress. We even participate in quality improvement initiatives. We also play a key role in patient education, food service management, community nutrition programs. What's important to note is that the nutrition or the NDTR credential isn't just a stepping stone for an RDN credential. It's a professional role in its own. NDTRs bring value through our technical knowledge, our clinical skills, and the ability to support RDNs by enhancing their workflow, improving patient outcomes, increasing access to care. I always say NDTRs are essential members of the nutrition care team. We don't replace RDs, but we absolutely reinforce them.
So thinking about kind of a day in the life of an NDTR, how does your role differ from an RDN, specifically in the clinical care setting?
So my role is different from an RDN because I'm seeing standard patients where the RDN is seeing the higher acuity patients. I'm doing a basic nutrition screening, an MST score of 2 through 4, like at our facility, MST score, malnutrition screening tool. And we're asking, are you nauseous? Are you vomiting, diarrhea, constipation? Just the basic questions and stuff like that. Are you eating okay? Do you have wounds? Do you have this? And then, if they've lost weight, if they've if they're not eating well, if they have dysphagia and stuff like that, then once they start meeting these criteria, then you're like, okay, you've hit all of these criteria. I'm going to shoot you up to the dietitian. You've met that criteria. If I'm marking no to all of this, then you're just a standard risk patient. I'm going to follow you through your stay. I'll typically do some meal selections with you. If you have like some moderate appetite, you need some high protein, I'll do some selections with you, do some high protein snacks or do some supplements, something like that. But, depending on the patient kind of thing.
Okay. And in what ways can the NDTR help improve the productivity of a dietitian in a healthcare facility in particular?
Yeah, so we can definitely take away their larger caseload so that they can see higher acuity patients. So while they are taking on the TPNs and the tube feeds and stuff like that, we're seeing the lower acuity patients.
So I'm a dietitian in a clinical setting. We work together, in this scenario. So what tasks or responsibilities would be appropriate for me to delegate to you in our roles?
Okay. So this is a very important topic because its effective delegation really comes down to the understanding of what the NDTR scope of practice is and their individual competencies. Say at my facility, like I had mentioned before, we use the MST score, the malnutrition screening tool. NDTRs, like myself, we screen patients from 2 to 4, as mentioned. We also do patients over the age of 80. And then length of stay. So if they've been at the hospital for 7 days or longer. Then we will escalate a patient if they've been or if they have an MST score of 5. That is an automatic RD assessment. If their BMI is less than 17, that is also an RD assessment. And then obviously if it's the TPN or a tube feed, that's an automatic RDN assessment as well. They're automatically seen. When it comes to delegation, NDTRs are often tasked with the nutrition screenings, follow-ups, and documentation of their own patients and basic education, monitoring the outcomes of the lower risk patients. But that doesn't stop there. Just like RDs, nutrition or diet techs have their specialties as well. And typically we like to thrive off of having our niches as well. For example, some of my coworkers specialize on heart healthy patients or oncology. I thrive off of wound care. I love wound patients. A big part of my caseload includes trauma and neuro and med-surg patients. So I've built my competencies around wound care training to better support those patients. So what's appropriate to delegate to an NDTR really depends on their education and training and experience, as well as the trust and collaboration between the RD and the NDTR. We need to lean on each other against each other's strengths and ensure competencies are in place. Delegation becomes not just appropriate, but a huge asset to patient care. As I mentioned with like the wound care, me and my dietitian on my trauma unit, we are working on a Juven project. So when I'm allowed to order Juven at my hospital, and when I feel that it's appropriate for this patient to have it, because they have like a stage 3 or stage 4, I will order them Juven, and I will provide them wound care education, and I will provide them like high protein food, depending on how they're eating. And then when I order them Juven, they automatically have to be seen by the dietitian for a full assessment. At that point, my dietitian will determine, do they need to be high risk or do they need to be standard? Typically, my dietitian will flip them back to me, because if they're eating really well, they're taking their supplements, they don't need to be high risk. So she'll just shoot them back to me, and I make sure that they're following, their plan of care. And that's because we've established that trust with each other.
I say, can you share some examples of how effective NDTR utilization can positively impact a clinical workflow or even patient outcomes? And it sounds like you just gave an example of like a wound project that's definitely going to have positive outcomes.
Yep. Absolutely. I've seen some really great examples of how NDTRs can enhance both workflow and patient care when they're utilized to their full potential. I know a hospital, I believe in Kentucky, that they utilize diet techs on their tube feed team. They obviously are not dropping tubes because they're not CNSCs, but they are assisting on the tube feed teams. They're making the patient comfortable. They're wiping down the core track machine. They're doing the documentation for the dietitian, which allows the dietitian to continue dropping more tubes. That's allowing that workflow to flow a little bit more because that diet tech is assisting. So that it's freeing up their time because that diet tech is there, cleaning and documenting for them. In another facility, a DTR was trained to assist in indirect calometry in the ICU. This was a game changer for that RD team because they were stretched thin. I think there was only like 1 or 2 dietitians that were actually doing that. So they trained the NDTR to handle the technical aspects of the metabolic testing. So the RDs were able to focus on the complex assessments and interventions while still ensuring that the data needed for accurate energy prescriptions was being collected in a timely manner. And then, like I said, with the Juven project, I was assisting with the wound care just to justify that we need to add Juven to the MAR so patients can receive the supplement as intended. By supporting this project, improve the process and outcomes for patients with pressure injuries and other wounds. These examples show that NDTRs, if they're properly trained and trusted, strategically used, we can directly contribute to better delivery, better care delivery, improved outcomes, and be more efficient to the clinical care team overall.
Well, you made a comment earlier. I want to circle back to talking about the dietitian being stretched too thin. And I think we hear that a lot in the clinical setting. We're short staffed, the patient loads are increasing, and dietitians just struggle to keep up sometimes, right? Some days are better than others, but still. So how can an NDTR really help improve the timeliness and then also the consistency of those nutrition interventions?
Absolutely. Involving the NDTR in patient care can significantly improve both the timeliness and the consistency of nutrition interventions because we help close the gap between when a need is identified and when care is delivered. We're often the first touch point after a screening, which allows us to gather relevant data. Then we follow up on the concerns, reinforce prior education, and communicate important updates to the RD quickly. when NDTRs are integrated into the care team, patients are less likely to fall through the cracks. For example, if an RD is managing a full caseload, the NDTR can step in and ensure the patients are still being seen, especially those at standard or moderate risk. This helps ensure timely monitoring and continuing of care. It also keeps the patient experience consistent. Someone from a nutrition team is going to keep following up and educating them. Even small steps like, rechecking a patient's intake, reminding them about their supplement schedules, flagging early signs of decline can make a big difference in preventing complications overall. So in short, NDTRs can help the nutrition care process moving forward. No unnecessary delays, but better follow through, and more responsive approach to the patient needs.
So in your experience, what are some best practices for integrating NDTRs into a multidisciplinary clinical team?
One of the best practices for integrating NDTRs into a clinical team is to start with a clear understanding of what our scope of practice is, and the competencies. When healthcare providers, especially RDs, nurses, and physicians, know what an NDTR is and what we're trained to do, it opens up the opportunities for collaboration and delegation that truly support patient care. Another key element is communication. NDTR should be part of the interdisciplinary rounds, when possible, to include in team huddles or handoffs, just so that they're involved with things. We're part of the team. We're part of the patient care. We should be involved with all of that. This keeps everyone in line on the patient care plan, allows us to provide valuable input, especially when we're monitoring intake, reinforcing education, or following up in interventions. There are times that I'm looking at a patient and I'm noticing that their blood sugar is all the way up here, but their renal labs are all the way down here, and they're on a regular diet. And I'm like, what are we doing here? And the doctor's like, well, what should we be doing? And I'm like, what do you mean, what should we be doing? We need to be, adjusting our diet. Like, what? And they're like, well, what do you recommend? I'm like, oh, well, I recommend a carb control diet. Maybe put them on a renal diet. And they're like, oh, okay. And I'm like, hold on, you want to actually listen to me? Oh, wow. Okay. Training is also essential. So if an NDTR is expected to work in a specific area, like wound care or oncology or GI, it is important that they receive proper onboarding. I have several units. I have, like I said, a trauma unit. I have an entire brain and spine unit, like neuro. I have a correctional unit. I have a GI unit. I have bariatric. I have all of these units. And I had to take on the GI unit. And I was like, when I take this on, I need full education before I take this on, because that is a beast in itself. It's like, I will not take this on until I get the proper education.
Right.
And thankfully I got the proper education, and me and my RD have a great relationship with each other. And that's my phone. We have a great relationship with each other, and I'm able to pick her brain whenever. And she will tell me, like, this patient does not need to be a high-risk patient, and she will explain to me why. And we're allowed, and we have that type of relationship with each other, and she'll break things down to me, and I appreciate that. She gives me the proper feedback, and she's a great mentor to me. So I greatly appreciate that from her. So like I said, having that relationship with your RD is very important as well. But finally, trust and mutual respect goes a long way. So when RDs recognize the value of their NDTR, NDTRs feel supported and empowered, then the entire team benefits from this. Integration isn't just about assigning tasks. It's about creating a collaborative environment which each role is used to its full potential for the good of the patient.
So for our listeners who maybe don't have NDTRs at their facility, but they're looking to add that expertise to their structure and work plan, how would you recommend they structure that supervision and collaboration relationship between the dietitian and the NDTR to ensure optimal practice, but also staying within the SOPP guidelines?
Oh, that's a great question. They should structure the supervision between the RDN and the NDTR based on the Academy's definition of general supervision, which means that the RD doesn't have to be physically present at all times, but should be available for guidance and support, oversight when needed. I mean, I'm all over the hospital. I'm running around I never see my dietitians. Maybe I will see them in passing. I will send them a epic chat saying, hey, I'm making this person high risk. And they're like, cool. They'll send me a thumbs up or, hey, thank you. Like, maybe I'll see them every once in a blue moon at a team huddle or something like that. Like, hey, I'm your diet tech.
Mm-hmm.
But, that's pretty much it. The key is having clear protocols in place. That's why we have policies and procedures and all of those fun roles that every place has that define what tasks can be delegated to NDTRs and under what circumstances. We all have our rules. We know what we can and we cannot do. And we know what lines we can't cross. The collaboration works best when the RD and the NDTR have open communication. I know how to communicate with my dietitians. Some want me to email them. Some want me to text them. Some want me to message them in the EMR. You gotta figure out how you want to figure out or how to communicate with each one of them. I have 4 dietitians, and you got to figure it out.
Mm-hmm.
It's super easy after you figure it out. And then NDTRs take up, some dietitians may be okay with you taking on their educations. Some may be okay with you taking on their follow-ups. Some may be like, okay, I want to take on this education, but you can take on these educations. Mm-hmm. I'll take these consults if you take these consults. So it's like, I have all these lists, like this dietitian likes this dietitian likes this. So you just kind of got to figure it all out. RDs focus more on the high acuity patients as we've mentioned many times. But the NDTRs help support the day-to-day workflow. So if my dietitian's like, hey, I have a patient that needs a meal that needs to be set in for every day. Can you do this for me? I got you. Like, I'll just plug it in. They'll have me do those like little tiny tasks. So that's the type of general supervision that we can do because they're so busy doing those calculations for the TPNs and all of that stuff where I can go in and put a lunch menu in for the next 5 days.
Sure. So, Sami, do you have any advice for maybe a clinical nutrition manager who is thinking about expanding the role of an NDTR within their department?
My biggest advice would be don't underestimate the value and versatility of a well-supported NDTR. Start by reviewing the NDTR scope of practice. That is the most important thing. Then evaluate where the RDs are stretched then. Are there tasks like follow-ups, educations, routine screenings that need to be delegated? Many DTRs are eager to specialize. So whether that's food service or med surg, heart healthy, wound, oncology, all of those, provide opportunities and focused training or niche development somewhere in that. NDTRs can become key players in supporting clinical workflow and improve patient care. I've seen NDTRs thrive when they are empowered to lean into their strengths. It is also essential to build a collaborative environment where RDs and NDTRs communicate regularly and work in a partnership. Include NDTRs in team meetings, in the rounds, in department projects. When they feel involved and valued, their impact grows. And lastly, invest in ongoing education and mentorship. Supporting NDTRs through cross-training and continuing education and even leadership development strengthens your department from within. Expanding the NDTR's role isn't just about efficiency. It's about building a sustainable and empowered nutrition care team.
Well, Sami, just one last quick question before we wrap up. If you were to look into your crystal ball, where do you see the future of the NDTR profession in clinical care? And what can organizations do so that we can leverage this specialty and improve our patient quality?
Looking into my crystal ball, with more NDTRs advocating for our role and visibility, I see a future where we're fully integrated in clinical care teams, not just as support, but as skilled professionals operating at the top of our scope. I'd love to see more NDTRs on tube feeding teams, assisting with devices like CoreTrack, or working on ICUs, helping with indirect telemetry and things like that. These are areas where NDTRs can make a meaningful impact, especially when RDs are focused on higher acuity patients. To better leverage NDTRs, organizations need to move beyond just filling entry-level roles. Instead, they should look at our training, look at our credentials, and our potential. Give us the space to grow through continued education, and our potential. Give us the space to grow. When we're empowered to work at our full scope, we're not only improving our efficiency, we improve the consistency and quality of our care across the board. So the future of NDTRs in clinical care is bright, but only if we're given the opportunities and trust to shine.
Well, Sami, thank you so much for sharing your viewpoint and your expertise on this issue. NDTRs obviously bring a ton of value to the profession, so I really appreciate the opportunity to highlight it here on the podcast. So thank you so much for spending your time with us today.
Yeah, thank you so much for having me.
And listeners, encourage you to visit our website at dnsdpg.org. We have a ton of resources available, many of which are free for our members. And of course, you can view the NDTR scope and standards of practice on CDR's website at CDR.net. So check that out today. And again, until next time, I'm Christina Rollins. Thanks so much for listening.